Hello? It's on. Hello! So we'll go ahead and get started since it's 4 minutes after 4. We do want to welcome Heather and Kelly from the Care House. And so we're so excited about having the after school program inside the Dream Center, but also we're going to be dealing with kids even if you're not in the after school program, whether it's in the church side or whether it's actually in the Dream Center while we're feeding kids, whatever it is, we're going to be around kids and something is going to come up that pulls at our heart, and we're going to have to know, what do we do with this? The best way to go about this. And so these people specialize in it, and so we are so grateful to have them. And then also we were saying that we want to make sure all these recordings go out to everyone as a requirement, specifically with kids. We want everyone to get this information. So even though this is earlier than when we would normally train, at least we'll be able to get this out to everyone. Just so you know, Wes McDonald, who also will be a big part of the Dream Center, he's working on putting it together on YouTube, all of the trainings, so everybody can have them, even if somebody's missed something, people are working, busy, whatever it is, kids' sports, all those things that happens in life. But anyway, at this time, I'm going to welcome the Care House to come tell us all about what we need to know. And remember, if you have questions, make sure we get the mic so we can hear the question to understand the response. Thank you.
Thank you all for having me. My name's Heather Hackett. I actually work at Dayton Children's Hospital. I've worked there for about 5.5 years now, and did my master's internship there prior to that as well. So I am very happy to be here today and talk with you guys about child abuse and ways to identify, respond to it, and hopefully prevent it. I'm used to very informal trainings, so you guys are more than welcome. If you have questions in the moment, please go ahead, shout it out, raise your hand, whatever you're comfortable with. I'm happy to answer questions as we go, and then if there's more questions at the end, we can always go over those as well. So feel free to jump in at any time if needed. So I thought first we'd talk about the role of a medical social worker within child abuse at Dayton Children's, just so you kind of understand my role, Kelly's role, and then how we interact with Care House and the different advocacy centers out there. So we do what we call psychosocial assessments. So we meet with families, we gather a lot of information from them. We talk about different support systems they have, different risk factors, things that they're experiencing like mental health, substance abuse, involvement with law enforcement or children's services. And we talk about different community services that are involved and ways we can help link them with that. And then we make mandated reports when necessary, and we'll talk a little bit more about that later. We work with 3 child advocacy centers that are hospital-based, so Dayton Children's owns them. So that's Care House in Montgomery County. We have Michael's House, which is Greene County, and Warren County Child Advocacy Center. And then we also are a part of the multidisciplinary team through Clark County's Child Advocacy Center as well. And so the child advocacy centers, like I said, consist of a multidisciplinary team. So they have forensic interviewers, they have law enforcement and children's services typically housed out of the center. They also have mental health services, medical services, so the part of the team that I'm on, where we do exams and things at the advocacy center or at our clinic at the hospital. And then they also have victim advocates and prosecutors who are part of that team. And they complete the forensic interviews anytime there's a concern for a child that is verbal and able to complete an interview, when there's concerns for child abuse or neglect. And then they help coordinate with other members of the team to make sure we get all the services needed for that child, so whether that's mental health or a medical appointment as well. Some of that we do all within the same day. Some of it we have to kind of do different times based on the family's needs at the time. Some of our other role as a medical social worker is to coordinate with law enforcement and children's services. So not only do we make those reports, but after reports are made, we help communicate the medical information, we help coordinate any follow-up care that there may need to be for that family. And then we refer to all kinds of community agencies as well. So this is probably the only time I'm going to read the slide to you, but I think it's really important to understand what the definition of child abuse is, and that is a recent act or failure to act on the part of a parent or caretaker which results in death, serious physical or emotional harm, sexual abuse or exploitation, or an act or failure to act which presents an imminent risk of serious harm. And that is CAPTA, which is the Federal Child Abuse Prevention and Treatment Act. That is the official kind of diagnosis or definition of child abuse. So in 2016, there were 676,000 cases of confirmed child abuse in the state of Ohio, child abuse and neglect. And so I thought it would be good to kind of talk about this data first to kind of understand what the problem is. I know this probably seems like a while ago as well. This is the most recent data that we have through the Ohio Children's Trust Fund. So approximately 90% of the child victims were abused by a parent or caregiver. The highest rate of abuse occurs within a child's first year of their life. That is when they are at most risk of abuse, specifically physical abuse. So within those 676,000 cases of child abuse or neglect, there were approximately 79,000 reports made. And so the reason that number is lower is oftentimes reports are made for multiple children at once, whether it's multiple children within one home or multiple homes or a family that they're reporting, and there's numerous kids in different homes. So within those reports, 90% of those, oh, I'm sorry, I already talked about that. 32% of those were neglect, and the majority was 37% physical abuse. 11.5% was sexual abuse, and then 17.5% of those reports were multiple types of either abuse or neglect. So children that were victims of multiple types of maltreatment. So then this is data specifically for CareHouse over 2020. They had 965 children that they served. So that means children that had forensic interviews as well as children that were too young to be forensically interviewed. So oftentimes those are our physical abuse cases where the children can't verbalize what's happened to them, but the CareHouse or the child advocacy centers that we work with still help coordinate that multidisciplinary response to make sure that the child's getting everything that they need. So this kind of just shows you a little bit of the percentages of sexual and physical abuse and neglect that they do. We do see human trafficking as well, which is often not thought of as being something that happens domestically and specifically not in our community, but is something that we see often as well. And then it kind of breaks down with ages and gender as well. So talking about the different forms of maltreatment, within the definition it talks about them being acts of commission as one of those types. So an act of commission is where you see things like physical abuse, sexual abuse, human trafficking, whether sex or labor trafficking. Munchausen syndrome by proxy is probably a term you may have heard, which is now referred to as medical child abuse. The new term actually relates the diagnosis to the child versus the perpetrator who is doing it to the child. So we refer to it now as medical child abuse. And then emotional and psychological abuse. And then we have our acts of omission, which are where you see our neglect. So that's physical and medical neglect. Malnourishment and obesity are also considered forms of neglect. Drug exposure, whether that's the child is born exposed to a drug, positive for a drug like cocaine or heroin, or there's drug exposure within the home of a caregiver or family member using drugs. We also see kids often that are not in school, not enrolled in school when they should be, so that's educational neglect. Abandonment. There are different laws in Ohio and other states for what the term abandonment means. And then supervisional neglect, so something like someone's supposed to be watching the kids but no one's home and there's a 2-year-old home alone. That would be supervisional neglect. So talking about the effects of child maltreatment, It affects physically, mentally, emotionally kids. There are increased risk of medical conditions. So this lists off diabetes, lung disease, arthritis, blood pressure. All of those can be long-term effects of kids that have experienced maltreatment. Brain development is also something that we can see changes in, where there's either deficits or delays, different ways that they now process information and respond in situations based on that history of maltreatment and trauma. And then I'm not sure if you guys have heard of the ACEs study before. That's the Adverse Childhood Experiences. But that is where we see a lot of the long-term effects of what these kids experience as kids. So there's 3 categories that the ACEs study kind of breaks this up into, and that's abuse and neglect, and then household dysfunction. So in our abuse category, that's physical, sexual, and emotional abuse, which we'll go through each of those in a few minutes. In our neglect category, that's physical and emotional neglect. And then in our household dysfunction, that's mental illness, mother being treated violently, divorce, incarcerated relative, and substance abuse. So all of those factors are considered adverse childhood experiences that can have then these other lasting effects that may be a little hard for you guys to read. They're kind of far away. But things like physical and mental injuries, mental health diagnoses such as PTSD, depression, anxiety, increased risk of suicidality, unintended pregnancies, STIs, HIV diagnoses, other medical conditions, and drug and alcohol-related disorders. There's also risk factors that we see that put kids at a higher risk of being maltreated. So one of the things that we always say is that abuse does not discriminate. Abuse can occur in any home. It doesn't matter whether they're with parents, grandparents, aunts, uncles. Doesn't matter what socioeconomic status the family is. Abuse can occur everywhere. And we often talk about how there may be biases against a family that may appear dirty, may not be as nice as we want them to be, and thinking that those kids are at higher risk than the family that is put together, that comes in being so kind and answers all of your questions and is the most cooperative family. But we know that it can occur anywhere, so we look at very objective information to determine if there's concerns for abuse or neglect. Children under the age of 4 are at higher risk. Kids that have developmental or cognitive delays as well. In regards to caregivers, when they have their own history of abuse or neglect, that does raise the risk. It does not mean that they are going to then abuse their children, though, but we do see a higher risk for that. Substance abuse and mental health disorders, being young parents, part of that can be lack of education, lack of understanding of child development, and so that can lead to higher risk for these kids. Lower education, lower income makes life a little bit more difficult, when you are at a higher stress level because you're constantly worried about your finances. That can put kids at higher risk as well. Single parents or parents with a lot of kids, that stress that those parents can experience. Non-biological caregivers in the home that are caring for the kids. It's unfortunate to say, but we often see a parent's significant other as a perpetrator of maltreatment on a child, more so than sometimes other non-relatives or family members. And then additional stressors such as domestic violence, unemployment, seeing and witnessing other community violence, whether that's at school or just within the neighborhoods that they live in, and homelessness as well. So we talk about risk factors. We always want to talk about what the protective factors are. So things that we also call like resiliency within the families, things that help protect them from maltreatment. One of the most important protective factors is a community that is educated in and feels collective responsibility for preventing abuse. So that's you guys. It is so important to have people who work with kids, who volunteer with kids, who have kids of their own to be educated in this area, to know ways to prevent it, and hopefully intervene, if they do see something happening. Access to basic needs, so we're talking food, clothing, housing, job, all of those things help to give these protective factors. It's kind of the opposite of those risk factors. Having stable family relationships and healthcare is also very important. That's kind of a whole nother topic, but having access to appropriate medical care, especially when we're talking about medical or physical neglect, oftentimes that can be lack of insurance, lack of transportation to get to the doctor's office and to get, the child to a dental appointment, and so now they have teeth decay. So access to health care is also very important. So recognizing child abuse, that is something that is a collective responsibility, like we just kind of talked about. It's not just one person's job, it's everyone's job within the community, within families, to recognize when something's happening and intervene and help protect that child. So the 4 major categories that we'll kind of go over are the physical, sexual, psychological abuse, and neglect. So we'll start with some physical abuse. We talk a lot about sentinel injuries, especially at the hospital. That is a term that most people are pretty familiar with. Sentinel injuries, if you think of, I don't remember if it's a Marvel or DC character, but there's a sentinel that is a superhero who stands guard and watches over. And so that's kind of what a sentinel injury is. It's something that warns us of bad to come. So when we're talking about sentinel injuries, these are early signs of abuse, and these are physical signs of abuse. So a small bruise that may seem pretty minor and may not look like it's abuse in nature. A parent says, oh, the kid fell on a toy, but it's on a part of the body that typically would not result from a fall. That would be what we consider a sentinel injury. Oftentimes when we see kids with sentinel injuries, sometimes we find that they had those injuries when we're seeing them for more significant things. So they come in for a brain bleed, and we see that they have history of having bruising on their cheek before. That's what we would call a sentinel injury. So those are kind of things that we want to help you guys understand and look out for, so that if you see these smaller things that aren't that noticeable abuse, it's not a kid covered in bruises, but that's the time, we really want to intervene when we're first seeing these signs. The 10-4 rule, if you remember only one thing from this training, that is a really good thing to remember. It stands for torso, ears, neck, and under the age of 4. So those are the most uncommon areas for accidental injuries, and we'll talk more in detail about areas of the body and what's accidental, more so in nature than inflicted, but the torso, ears, and neck are very uncommon for being accidental. And then under the age of 4, there's much higher suspicion for abuse when those areas do have injury. Under 4 months is for any bruising. So a baby that doesn't cruise should not bruise. If that baby can't move around on their own, there should never be any injury to that child without a specific incident that a caregiver or parent is aware of. If a baby falls off of something, someone's going to know that because the baby who can't move is now laying on the floor. And if that baby had a little bruise on the forehead and they found face down, maybe that would be consistent with that injury and we wouldn't be concerned. But if you have a baby with a bruise on the forehead who can't move around and parents said nothing has ever happened to this baby, we're going to be concerned because they should have a history for how that happened. Considering the developmental age and ability, so even after 4 months of age or 4 years of age, considering what can that child do and whether it's makes any sense for them to be able to have caused that injury to themselves. Again, if you have a kiddo that's kind of total care, they're in a wheelchair, they can't eat or go to the bathroom on their own, and they have bruises on parts of their body that you wouldn't expect them to, we would be concerned about that as well, because developmentally, even if they're 16, they can't do those things, we would be worried about that. So some examples of physical abuse injuries that we'll talk about bruising, burns, and fractures, abusive head trauma, and we'll just slightly touch on some internal injuries as well. So bruises, they are the most common injury that you see in kids that are both accidental and non-accidental. So if any of you have ever had kids, I'm sure they have been covered in bruises before. You probably have seen bruises up and down their shins, on their knees, on their elbows, on their chin, their forehead. Those are really common areas for kids to have injuries because what do you think about those? Those are spots when kids fall. That's how they land, you know? So those are the most common injuries that we see in kids, but it's also a very common abusive injury. So what do we look for when we're looking at bruises? One of the biggest things is location. So we want to know, where do these bruises happen, especially if a parent talks about, oh, my kid bruises all the time. So I ask them often, can you tell me about those bruises? Tell me where on their bodies they've had bruises before. Common sites like we talked about, bony prominences. So anywhere where a bone sticks out of your body, you're more likely to bruise there. Anyone, whether kid or adult. And the head is a pretty bony thing as well. So whether it's on the front or the sides of it, the actual skull itself is more common to have an injury on as well. Especially little ones, babies are top heavy, so oftentimes we see accidental injuries more so to their head, because when they fall or roll off of things, the majority of the time the first thing that hits the floor is going to be their head. Uncommon sites, so we talked about the torso, the ears and neck. So the trunk is part of the torso, but we're talking abdomen, so the belly area, pretty soft, their chest, their back when it's not over the spine, genitals and buttocks. The reason the trunk, especially the abdomen, the back, and the buttocks, and we'll go ahead and we'll throw in the thighs too, those areas are pretty fatty. Even on little kids, they don't have a bone directly underneath of the skin like our shins or knees or elbows. And so when a child gets injured in one of those spots, it actually takes a lot more force in order to bruise that area. Because there's nothing for that skin to get smashed up against when they fall and land on their side or land on their butt, especially a diapered baby, than if they were to land on their knees or their shins or elbows. The ears and the neck are also pretty protected areas. If you think about your ear and you were to fall over and hit your head, the majority of the time you're probably going to hit this part of your head if you hit that side of your head, right? You're not landing directly on your ear. The ear is pretty much made of cartilage, and so there's not a lot of blood flow, so it's pretty difficult to bruise an ear. So we become highly concerned when we see kids with ear bruising. Whether it's on the sides, the bottom, or the back of it, we would be pretty concerned about that without a pretty specific and detailed story to make sense of that injury. The neck is also very protected. It's also very soft. So we many times are more concerned about internal injury of a neck before we would ever see external injury. It just takes a lot more force to bruise a neck. If a kid, just as a side note, ever talks about being choked or kind of blacking out and doesn't know why, things like that, we would always recommend emergency medical treatment to make sure there's nothing internally happening and that they can breathe and everything okay, because those can be signs of asphyxiation or someone choking a child. And then we talked about that 10-4. So these little pictures, I know they're probably a little hard to see for you guys, but you can see the accidental areas. The one it kind of looks like in the blue that it's covering the butt, it's actually covering what we call the flank. It's right above the buttocks, and you can actually feel bone there. So that area, again, kids often can have bruises there, and it hits a bony spot, so we're not overly concerned about that. But when it hits the soft parts of the buttocks, that's where we'd be more concerned. It just takes a lot more force. We talked about those who don't bruise. This chart, I think, is really helpful to see the percentage of kids that have bruises. If you see the first, these are in months. So the first 5 months, it is such a low percentage, and these are accidental injuries. So you see most kids that are under the age of 5 months don't really have any bruises. And the older the kids get, the more mobile and active they get, the higher there is a percentage and higher likely that they're going to have bruises on their body. Another important thing that we like to talk about because there used to be research that supported this that no longer does. You cannot date bruises. So oftentimes people think of bruises that are black or purple or blue as being new, and that yellow and brown bruises must mean that they're healing and from a previous time. And unfortunately, research just doesn't support that anymore medically. Everyone's bodies are very different. So when you bruise, you may bruise your elbow and your knee at the same time, and they may look differently from the get-go. We also can see at times where bruises can start more yellowish and darken over time. The amount of force that is applied when a bruise is when you get a bruise, that also dictates kind of how it's going to present on the body. So it can be very different, and we can't just reliably say that this bruise is older than this bruise. So you will not hear our providers in our child advocacy department talking in that kind of way. So now we'll talk about burns. And actually, I'm sorry, I did miss something about bruises, I just realized. We didn't talk about patterns. So when we talk about patterns, we're talking about things like loops, loop marks on the body, or linear, completely linear bruises are more concerning as well, especially if they're in an area of the body that's not typical. Now, there can be times that the kid runs into the side of a table and it's just right and it maybe bruises their leg, and our provider may agree with that and feel like that's consistent, and we wouldn't be concerned. But linear injuries are pretty specific for being some kind of object that has caused that injury. And so anytime you see anything that looks patterned, that's when we would be concerned about that. So burns also have patterns as well. Seeing things like cigarette lighters or from like an iron, unfortunately we see that at times. Immersion burns, that is when a certain part of the body is basically dunked and then held underwater, and it creates what we call like sock or glove-like burns, where, so if you look at my watch, there's a perfect circle around it. Imagine that being a burn. So if a kid sticks their hand in a boiling pot of water, they are going to immediately remove that when they feel pain. So that's going to cause splashing, and that's going to cause different areas of different level of burn based on how they stuck their hand in and how quickly they removed it. They may even have a burn on their upper arm and maybe their stomach or something from how they remove their arm from that water. An immersion burn is perfectly sock or glove-like, so it ends right at that circle. So that is very concerning for someone holding that child in the water because there's no splash marks or pattern or splash pattern from that. Non-ambulatory children, again, very difficult for them to burn themselves without someone being present. There are absolutely times that infants get accidental burns. Someone's hot water heater is up higher than they expected. They left the water running longer than normal. They didn't feel the water and they stuck the kid in, and the kid starts screaming and they take out. You know, that happens and we know that. But there's just a higher level of suspicion for itty bitties who don't move when they have burns. The location of the burn, any burns to genital areas are also highly concerning. Those tend to be more protected areas as well, so burns in those areas do hold that higher suspicion. Deep and large burns, so those are just more serious and significant, so those do have a higher level of suspicion. You know, we really want to get good details about how the burns occurred to make sure that it makes sense with what we're looking at. And then delay in seeking care for a burn. There are oftentimes families who, if another kid's been burned before, the parents had a burn, that they know what they were recommended to do. They feel like it looks similar, so they'll go out and get burn cream. They'll contact a friend who's a nurse or a family member, and they don't often bring in unless it starts looking infected. You know, those kinds of things we understand because they were treating it in the way they thought was best. But if there's been no form of treatment attempted, no contact to a medical provider, if the burn is pretty serious and significant, we would be very concerned with the delay in treatment of why did you not bring the kiddo in if it was accidental. So that can sometimes be concerning for being inflicted. I know I've talked a lot so far, so before we move forward to fractures, does anyone have any questions so far? All right. If you do, feel free to just pop that hand up or just shout it out. But we'll move forward then. So fractures, there are many, many, many types of fractures, and kids fracture their bodies all the time. It's a common way that kids end up at our hospital for accidental injuries. But there are times that we're concerned about those fractures. If there's not a history for the fracture, again, anything unexplained, any injury a kid has that's unexplained, we have just a little bit higher level of suspicion for abuse. And when I say the word suspicion, I don't mean we're treating the family with suspicion. Just want to clarify that. We are thinking more about the possibility of there being something inflicted, and we're asking a lot of good questions to make sure that we're getting the details and the history that we need to confirm that it is accidental and not something we need to be concerned about. But there are specific types of fractures that are what we call specific for abuse. Two types of fractures we'll kind of talk about today. One of them is a rib fracture. We often see these rib fractures in little babies more so. They're called posterior rib. So that is actually, I'm going to turn for you and show you. It is right here along the spine. It's right tucked in, kind of curved in from the spine on your body. So it is a protected area, and it's very difficult to actually fracture that part of your rib. You'll hear about people that have had CPR, more so adults than kids, but kids can get some fractures from CPR. But you'll hear about adults having broken ribs after getting CPR because you have to be so forceful to get that heart beating again. That does not happen quite as often with kids, and that is never a posterior rib fracture. The way that you perform CPR when done appropriately would not cause this fracture. What we usually see as a cause for this fracture is a squeezing mechanism, and it's most often seen in infants. The way that your hands curve around their chest, unfortunately, your fingers kind of go right in that area, and if you squeeze hard enough, it can break. Kids, there's often this idea that kids' bones are actually more fragile than adult bones, and it's actually the opposite. So kids' bones, especially infants, they are very malleable. So they're able to move and flex. If you think about how a baby's born, their bones have to be able to bend and move without breaking. So as you get older, your bones calcify more. And so our bones are a little bit more brittle than babies' or young kids' bones. So they're harder to break and take a lot more force. So those posterior rib fractures are pretty specific for abuse. Again, there would have to be a really good detailed history that would make sense for why a kid would have that and us not be concerned for abuse. There's also another type of fracture called a CML, a classic metaphyseal fracture. It's kind of hard to say. It is also known as a bucket handle fracture. So you'll hear another word, a buckle fracture, and then a bucket handle. So those are two different types. Buckle fractures can absolutely be accidental. We see those a lot with kids, especially when they fall and they catch themselves. They can sometimes get those buckle fractures on their wrists. A CML, or a bucket handle fracture, those are fractures of the end of a long bone. So your long bones are like your femurs, your tibia and fibia, and then your arm bones as well, your ulna and radius. So the ends of those bones, what can happen is the end of the bone gets pulled and separated from the long part of the bone, and it creates a fracture on the end of it. And that we often see with pulling and yanking on limbs. And so that is pretty specific for abuse. There's not really much that can cause that accidentally. And so we would instantly be concerned if we saw a kiddo with that kind of fracture. Again, more often seen in younger kids. I want to bust a myth as well, because a lot of times we hear spiral fractures, and it used to be something that was instantly thought that must be abuse because you think of it having to be a twisting motion. But we actually see spiral fractures often in mobile kids who are running and their foot gets stuck and they fall and they twist their leg and they get a spiral fracture. So that is no longer something that's instantly thought of as abuse. It's actually pretty often accidental, but it could be abusive. So we always consider the story and the mechanism for how the injury occurred and go from there of whether or not we're going to be concerned. Having multiple fractures in different areas of the body is also concerning at times for abuse. If you have a kiddo that has, a leg fracture, an arm fracture in different sides of their body, and they also have a skull fracture, and they're only reporting a little fall off of a bed, we would be pretty concerned about that because you need multiple points of impact to create fractures on different sides of the body and on different planes of the body. So you're talking your head, an arm, and a leg. So we would have a higher suspicion with multiple fractures. And again, those non-ambulatory kids, doesn't mean they can't have a fracture. We see a lot of kids who fall off of beds or fall off of couches, changing tables when they're infants, and they get skull fractures. And we're not necessarily concerned about that outside of talking about safety of, not leaving a kid unattended on a bed, don't step away for a moment, that sort of thing. But again, there would have to be a pretty detailed story for us if there is a femur fracture in an infant for us to not be concerned about that. Abusive head trauma. So that is most oftenly referred to in the past as shaken baby syndrome. That term is still used at times, but we have transitioned more so to abusive head trauma because there's more than one way, such as shaking, for a child to have this type of trauma to their heads. So we can see that, you see on the slide, there's a couple different ways talked about there. It's not just shaking that can cause brain bleeds and things like that. There is something we call retinal hemorrhages, which are bleeds within the eye. And there are certain features of a retinal hemorrhage that would be specific for shaking, and that's outside of a pretty traumatic car accident. There's no other way accidentally that you would get those. So at that point, we would be pretty concerned that the baby was shook. But when a baby has a skull fracture or a brain bleed with no history of trauma, we can't say that it was shaking necessarily over some other form of trauma that was caused to that child. So that's why we use this newer term of abusive head trauma. We also see a lot of non-specific symptoms in kids that have abusive head trauma. So they'll come in a lot for things like vomiting, or we'll have a parent talk about the baby started to have a seizure and they never had seizures before, or the baby just stopped breathing all of a sudden, and it took a little bit before the baby started breathing again. Most often when we have kids present to the hospital with abusive head trauma, they're not presenting with that being the history or the story. Parents aren't typically, or the caregiver, whoever's with them, are not typically sharing that kind of history. They're more so talking about, we noticed these symptoms, the baby was fine, and then all of a sudden this happened, and we don't know why she was seizing or shaking, or there was that change in consciousness where she seemed like she was asleep, but she wasn't waking up. Those are most often the ways these kids present. And so we have to, again, get very good histories about what happened before, what happened during, what happened after, to try and figure out, is there a medical cause that's causing the seizure or the unresponsiveness, or was it something else? And we often use different types of imaging, so a head CT or a CAT scan. We do different imaging of the bones of the body as well, and that can often tell us if there was a traumatic cause that maybe was the cause for those seizures versus it being something of a medical condition. So what is the most common trigger for an abusive head injury, do you think? We're talking mostly about infants. So can anyone tell me what they think would be the common trigger, something that would cause someone to maybe react violently? Yeah. Yes, they won't stop crying. Absolutely, that is the most common trigger for abusive head trauma. It's oftentimes seen as more of a reactionary type of abuse. It's not often thought out. It's not something that someone intends. The majority of the time, the person who did this to the child likely doesn't even realize what they did. A lot of times, the baby just stops crying, and they see it as something that helped the baby stop. Or the baby fell asleep in their minds, where maybe the baby was unconscious and they thought they were sleeping, and they didn't recognize that what they did caused a lot of internal injury because on the outside they look fine. Oftentimes, histories that we get for, especially when we identify like a brain bleed or a skull fracture, are that there was either no precipitating event, so nothing that happened before the unresponsiveness outside of baby was just crying and then fell asleep, or that there was some kind of fall or drop that was accidental that led to all of this. So things that we consider when we are suspicious of physical abuse. So oftentimes, the injury is more significant than what the history or the mechanism that the family is reporting. So like I said, they may report a fall, but this baby has maybe multiple brain bleeds on different sides of the head. And so that wouldn't happen from one impact, one fall. We also consider, like I said before, the developmental level. So whether or not a child is able to do this to themselves. So sometimes we'll have parents or caregivers. When I say parents, I'm broadly talking about all caregivers that can care for a child. But we'll often have them say that, that there's a bruise on the cheek, let's say, of a baby who's non-mobile, and they'll say, well, she always hits that side of her face with a rattle. Babies don't have enough strength to bruise their bodies themselves. Them hitting themselves with a toy, they don't have enough force, especially if we're talking about the fleshy part of your cheek. If you feel that right in the middle, there's not bone directly behind that. So again, that's one of those areas. It takes a little bit more force and pressure to cause a bruise there because it's not being slammed up against something like maybe the side of your head where it's directly against your bone. So not having that developmental ability to cause that injury would be more concerning. We also have parents provide inconsistent or changed histories. So maybe to the triage nurse, they say that they fell off of the couch and that mom was present. And then the doctor comes in and then they say the baby fell off the couch and then hit their head on a table nearby and mom was present. And maybe by the time a third person is there, they've added people to the room that now mom and dad were in the room when this happened and they both saw it. So changing histories is more concerning. A caregiver's concern or lack thereof, if they're minimizing the injury, especially significant injuries, minimizing it can be concerning. Not to say that not any of these. The developmental level is pretty standard, but if we're talking about like inconsistent histories or changing histories, we also know that traumatic events, you store information in your brain different than when you're just going through everyday life. So even if I were to go through maybe a car accident on my way when I leave here, so I am probably going to store that information in more of sensory ways. It's not going to be in a linear fashion, meaning it's not going to be at this moment this happened, the next moment this happened, the next moment this happened. It can be that way, but the majority of time trauma doesn't work that way. Our brains store it in a mishmashed way, and we don't always remember things appropriately. So there are times that parents misremember information, and we recognize that as well, and we try and piece through that and gather more information to figure out why that may be. But it just leads to more concern, when they're having different histories. Blaming of siblings and animals is a very common thing we see. We get a lot of blame of nonverbal siblings, so kids that can't tell us what happened or what they may have seen. We also get animals blamed for a lot of pretty significant injuries that an animal jumping on a baby or jumping on a younger kid wouldn't create. There are absolutely times that animals injure kids. There are times that dogs attack kids, and we see pretty terrible injuries from that are absolutely accidental. There can be times that dogs or cats scratch kids, maybe a bruise from something, but causing fractures, causing brain bleeds, things like that, we just don't see happening accidentally from animals. So we would have higher suspicion if they're reporting an animal caused that. Just a little brain break. I know that was a lot of information, and it's hard stuff to hear, and I recognize that. So I want to take this time to encourage you guys to do some self-care tonight. If you're not familiar with that term, that means doing something that you enjoy and something that makes you feel good. This is a lot of hard stuff to hear and probably not things most of you think about on a regular basis. This is kind of my life, so I'm pretty familiar with all these things, but even I have to take times and do self-care. So whether that's eat a junk food I really like, or listen to music or a movie that I wouldn't normally do on a weeknight, do something fun to just give yourself that relaxation and kind of decompress from all of this. So I encourage you to do that tonight. All right, so we're going to touch on sexual abuse. Sexual abuse can be very difficult to detect or determine when a child has not made what we call a disclosure. So a disclosure of sexual abuse is when a child tells another person that someone did something to my body. If they are under the age of 18, it doesn't even have to be that they didn't want it, and we'll get more into that in a little bit, but it's that someone did something to their body that they shouldn't have. There are signs and red flags we're going to talk about in a second. I want to kind of preface this by saying these are not necessarily, I don't even know that I would call them indicators of sexual abuse, but these are things that we can see with kids that have experienced sexual abuse, but these are also things we can see with kids that have experienced other forms of trauma, other life changes. We see some of these things with kids that have parents going through a divorce or some other, a death of a family member, things like that. So these are red flags and should be considered concerning, but it does not necessarily mean that sexual abuse is occurring if you see these things. So I just want to preface by that. So in young kids, things that we often see, sleeping difficulties, they're having nightmares, they're not able to stay asleep at night, they're coming into parents' bedroom every single night in the middle of the night. We see kids that used to be really social that are now more withdrawn. Maybe they aren't going up to family members as much as they used to. Anger outbursts, different mental health, so anxiety, depression. Anxiety and depression, when we see that in kids, it often looks different than when we see it in an adult. It's not necessarily this really sad child that just always wants to be by themselves and locks themselves in a room at age 5. We often see things like that where they're acting out, they're more irritable, they are more fidgety, they are not paying attention in class, they can't obey. Things like that can be more of those signs of something like a mental health or anxiety or depression versus what you see in an adult. Not wanting to be left alone with a specific person. Again, I want to say that can be very common for a lot of other reasons, including separation anxiety. That is real with real young kids that have never been in daycare, that all of a sudden are going to a new provider, they're changing schools, they're going to a family member that maybe they don't typically go to, and so they're just less comfortable with that. So again, that can be something that we see just kind of regularly, and so we always want to keep those other life situations in mind when we're considering sexual abuse due to behaviors alone. Sexual knowledge or language, that's not what you would expect for that child's development. If the child is using words or things that you have not taught your child or would not expect a 3-year-old to know, we would be a little bit more concerned with that. That's not to say that it's not something that they heard at home or heard by another kid, especially school-age kids. They hear a lot of things now at much younger ages than used to be. Social media is also a big thing. We have 3-year-olds who have their own cell phones. And so oftentimes they have access to videos and things that maybe 10, 15 years ago those kids would not have had access to, and so have more knowledge now. Having physical symptoms, you will have kids that will have a lot of stomach aches, or sometimes they'll get a stomach ache every time they're going to Aunt Josie's house, and you don't know why, because they used to love going to Aunt Josie's house. It could just be separation anxiety, but it could be something more. Headaches are often something as well we see. Bedding and daytime accidents. That's specifically in kids that are potty trained. So if you've had a kid that's been potty trained for 5 years and all of a sudden every night is having what we call enuresis, or a bedwetting incident at night, we would question maybe what happened before that started to see what could be contributing to that, whether it's a form of trauma or another life change. But that is concerning. So then, talking about adolescence, all of the previous things can also happen with adolescents. So we're just going to make it even more difficult for you with the teenagers. But we also see a lot of risky behaviors with them. So when we talk about risky behaviors, we're talking about running away, going and meeting people that they only met online and now they're meeting in person. They are using or experimenting with different substances, whether marijuana, other drugs, or alcohol. All of a sudden, a straight A student is now getting all Fs and skipping school and not wanting to hang out with their friends like they used to. They're isolating more. All of those things can also just be part of being a teenager. We know that kids experience a lot in those teenage years. Their bodies are changing. They are experiencing so much at school with other people, all of the social media and the impact that that has on kids having access to that 24/7. So we know that can be factors as well. But we also see a lot of these behaviors with kids that have disclosed sexual abuse. There are times, though, that kids have experienced sexual abuse or another form of trauma and do not show any of these signs. That doesn't mean that what they said didn't happen, but just recognizing that these signs can be present. A kid could have all of these and not be sexually abused, and a kid could have none of these and have been sexually abused. So just recognizing these are red flags, things to look out for, but don't necessarily mean that abuse has occurred. Sexualized behavior, that is a big thing we get, especially in our emergency department, from families. Their kiddo, who's 3, has started to hump a stuffed animal, and they are really worried about that because they've never seen their kid do that. This is their 3rd kid, and none of their kids have done that. And they typically get pretty concerned about that. That is actually a pretty typical, normal, healthy sexual development of a kid. A child touching themselves, wanting to peek in on the bathroom when another person, especially of another gender, is going to the bathroom, when these kids are 2 and 3, are really common as well. They're very curious. They're curious about their bodies, and they're curious about other people's bodies. When we get more concerned are with these less common or uncommon behaviors, and then there's a rarely normal column as well. And I don't know how well you guys can read those, but those are behaviors more so like rubbing their bodies against another person's body. That's less common. It doesn't mean necessarily that that's happened, that sexual abuse has occurred, but it is less common, just without maybe there being some kind of learned behavior, whether it's something they saw or something that happened to them. Touching an adult or a peer's genitals, again, there's often that curiosity of, you show me yours and I'll show you mine. That's very common and typical development. When it leads to touching of each other's genitals, that can be a little bit more concerning, and it's a little less common, not to say it doesn't happen. When there is progression from touching to then inserting objects in different body parts, that is not a typical developmental behavior without it being learned. So a kiddo doesn't just think of shoving a marker up their butt out of the blue. Now, is it something they heard someone say? Is it something they saw on a cartoon show on YouTube, that they were watching a show that was too old for them? Quite possible. But it could also be something that happened to them. So when you hear a parent or you see something, when you guys are volunteering, that doesn't seem to be typical, if you have that concern, we'll talk about reporting in a bit, but for those more rare things, anytime one kid is touching another kid, we would say go ahead and report that to the appropriate people. And like I said, we'll talk about who those people are in a minute, because we don't know at that point, and it's not your job to investigate, and we don't want you guys in that position to have to figure out, is this kid being abused or did he watch a YouTube video? So we would just recommend at that point reporting it, and we'll talk about that. Age of consent. Ohio is different from a lot of other states. Ohio's laws are confusing. They're confusing for kids and parents. They're confusing at times for law enforcement and children's services. So the legal age of consent is age 16. So that means a 16-year-old can have consensual sex with anyone from 13 up until 99, and it be legal. Most states, it's age 18, can only consent to another adult. So Ohio is a little different in that aspect. So a 16-year-old can have a relationship with a 26-year-old as long as there's nothing of what we call power over them. So they're not in a position of power such as a coach or a teacher. They're not a parent or aunt, uncle, someone in the family. If they are Joe who they met off of the internet and they met in person and started dating and having sex, that is legal. That doesn't mean a parent can't press charges. They can choose to do so, but there may not actually be any repercussions or prosecution from that because technically it's legal. Now, when we're talking about the ages of 13 to 15, they also have some ability to consent to others, and that is only to other kids in that same age range or up to age 17. So that's kind of the year range you want to think about is 13 to 17. They are allowed to intermingle with the different ages, but only 16 and 17 can with adults. It's very confusing, and I recommend you guys having this chart maybe at your guys' location. Just a quick reference, if kids do talk about their sex lives, kids do that. They're very open sometimes. And if it's something that you're like, ooh, I don't know that that's okay, having a quick reference may be helpful, especially if you're working with the teenagers. If a child is under the age of 13, so if they are 12 years old and they are having sex with a 13-year-old, unfortunately, that is illegal, even though they are 1 year apart. If that 13-year-old was having sex with a 17-year-old, that is legal. So it gets very confusing for people. So we are always, you'll have my contact information at the end of this, we are always open to people calling with questions because it's very confusing and it can be very concerning situations that feel like you can't do much about because technically by law it's legal. So, but general rule, if you're under the age of 13, if you're 12 and under, you cannot consent to anyone, even another 12-year-old. So that is something that it would be considered a mandated report, which we'll talk about. Does anyone, before I move on, because I know that's super confusing, does anyone have questions about that or anything else? Okay. Agreed. Yep. All right, so like I talked about before, human trafficking is something that we see in our own community. It's not something rare. It's not something that we only see here and there. We actually see fairly a lot, and we see it with a lot of our teen girls, especially girls that are in foster care, living in group homes, or often run away from home. The reason for that is because they are easier to access. They are people who maybe don't have others at home who are thinking about them and wondering where they're at 10 o'clock at night, or they don't get that love and affection that maybe someone in a home with a parent and siblings who care about them, and so they are actually specifically chosen for those types of reasons. So human trafficking, we often think of that being sex trafficking, but that is not the only type, but it is the use of force, fraud, or coercion to obtain some type of labor or commercial sex act. So that's any exchange of any goods for a labor or commercial sex act. So that can be anything from they bought lunch for you after performing a sexual act. In a minor, that is considered human trafficking. If they are under the age of 18, they are not able to sell services in that way. It is not called prostitution when you are under the age of 18. It is human trafficking. So that can also be in other forms, so not just sexual exploitation or forced labor, but we see that with debt bondage, domestic servitude, maybe not quite as often here, organ removal, forced begging, child soldiers, and forced marriage. I hate to say that we have had some of those cases in our own community here. Most often, though, we see more sex trafficking in this area. Ohio is at a higher rate of it, partially due to our highway systems. We have a lot of universities where sex trafficking often occurs as well. So there's just a lot of prevalence in Ohio because of those things. So medical exams, so this is kind of my world too, is being a part of the medical exams for kids that have experienced either acute or non-acute sexual assaults. So we often talk about, well, what is the exam? But the first things I think are easier to kind of understand are what is it not? Because there's so many things that people expect that don't happen when we see kids. This is not a OBGYN exam. It's not an adult exam. There's no speculum used. It's not something that's painful. Oftentimes people are telling their kids that it's really gonna hurt, just know what to expect. They're trying to prepare the kids, and it's not something that's painful. This is not something that is seen, and we know this from research and studies as well, but this is not something that's seen as further traumatizing a kid by having this type of an exam, and it is not a verification of virginity. We get a lot of parents that bring their teenage kids into our emergency department asking, I need to know if she's having sex. No one's gonna know. No one, because on exam, you cannot determine that. There are a lot of myths out there about the hymen breaking and all kinds of things that are not a thing. So we cannot verify whether anyone has ever had sex without them specifically saying that they have, or there being an injury that we can see on exam. And this is also not to prove that what the kid has said happened didn't happen. If a child discloses sexual abuse, we believe them and we move forward with that as fact. The majority of kids, even teenagers, who disclose sexual abuse are not lying. I'm just gonna leave that there for a bit because we'll go back to that. So what is our exam then? It's an opportunity to do a lot of different things. So we can identify injuries or infections. So there's numerous STIs that not only can we test for, but there's STIs we can't test for, so sexually transmitted infections, that we can only identify if we actually do a visual exam and see something like a lump or a papule, or they call it all kinds of different names, lesions, things like that. You can't just test for those things. We can often detect ongoing abuse or risk to other kids. So if one kiddo has disclosed something happening in their home or someone else's home, oftentimes they will disclose those things to a medical provider of happening to another child, if they're aware of that. It gives us an opportunity to reassure a child. Oftentimes, especially or sexual abuse at young ages, kids are very worried about their bodies. They don't know that their body is what it's supposed to be like. They don't know that there's nothing wrong with their body. They often have a lot of questions about what does it mean if they've been sexually abused. Does that mean they're no longer a virgin? Does that mean that they're not going to be able to have kids? We get that question pretty often. Does that make them gay, especially if that's been a perpetrator has been the same gender as that child? So this gives us that chance to reassure them, to make them aware of all of the health risks, but also to reassure them that they're healthy, that they don't have any infections, that their bodies are typical and what they should be, and kind of put to rest the fears that they may have. It can also do those things for parents as well. We talk a lot with the parent about what the exam does and doesn't mean. So it gives us that chance to educate about the exam with the caregiver, but it also gives us the chance to talk about how to support their kid. Most parents don't have any idea of how to go through this. They don't ever expect to go through this with their child, and it's devastating. And so talking with them about how they can support their kid through this, what they can do at home with them, is really helpful for those parents. And then assessing their mental health needs. We have on here the child's needs, but we also assess the parents' needs. We talk a lot about self-care with the parents and about seeking services for themselves as well, especially if it's a family member that has been the perpetrator. They often have conflicting emotions, and they don't know how to process all of that when it's someone that they loved that harmed their child. So where do these exams happen? We have a couple different places. So in our emergency department, we see kids most often for what we call an acute exam. So that is a sexual assault or abuse that has occurred in the past 72 or 96 hours. In that time, it allows us to do evidence collection. You'll often hear that referred to as a rape kit. We call it an evidence collection, and that is also not something that's painful. There are times, depending on what happened to that child, that they do struggle with the evidence kits emotionally. And so we have all kinds of supportive services that we can put into place to help them through that. They are always allowed to have their caregiver or whoever they want present for the exam and the kit. We have facility dogs, Millie and Peppermint, that often come to our clinic and the emergency department, and they help the kids through the exams, and the kids just love it. They get to cuddle up with them, the dogs get to show them what position to be in, and it just really helps to ease any anxieties that they have. They actually do that. That's called the frog position. The dogs are great about displaying that for the kids, and the kids love it. So, and then we also have all kinds of distraction things. So we have iPads where we can play movies, TV shows, play their favorite music. We have turned on Cardi B as loud as possible in our exam rooms where you can hear it down the hall because that's what makes that kid feel most comfortable. We have bubble machines and all kinds of Play-Doh toys and things like that. So whatever we think is best going to help that kid, and we ask them, what do you like to do? What's going to bring you comfort, during this? And they can tell us what they like best, and we can help make that happen. If we don't have it in our clinic, we will find it if we can. We also see kids in the emergency department, even when it's a non-acute, so it's past that 72 or 96 hours, but they're having pain or bleeding, discharge, anything that would be concerning for a possible infection. We want to see them right away. Adolescents are at really high risk of what we call PID, which is pelvic inflammatory disease, and that is when you've had a sexually transmitted infection that has now gone up into the pelvis. And so that can actually be deadly, and so we want to see those kids immediately to get them treated if needed. If there's behavioral or emotional concerns, we have a great crisis center and behavioral health team. There are times that myself and my coworker, Kimber, who we see during the day primarily all of these sexual assaults or abuse cases in our emergency department. So there's times we do mental health assessments with these kids, but there may be times where they're actively suicidal. And so we need one of our behavioral health workers to come in and do a full assessment and determine if they're safe to go home with whatever caregiver is there with them, or if they need a little bit of extra care for a few days to get them stabilized. So we would want to see those kids right away. And then our child advocacy clinic, we have a couple different locations for that. So we see all the other kids that have disclosed abuse in that clinic if they haven't come to our emergency department. We get referrals from all of our child advocacy centers. We get primary care doctors calling us, other children's services or police agencies out of the counties that we have the CACs in. So we get kind of from all over, we see kids. We service 22 counties, and I have seen a kid from every county that we service. So, but we see all the other kids who have made disclosures. We see kids in clinic who have other indications for possible sexual abuse. So maybe they've been displaying that abnormal sexual behavior, but they haven't made a disclosure yet. We'll see kids for that, or there are times that we get referrals from other medical providers that there's concerns for warts in the genital area, and that doesn't necessarily mean sexual abuse. There can be wart virus in the family that kiddo scratching or during diaper changes or something that's transmitted. So we see those kids often to determine whether or not we're concerned for sexual abuse in that instance. We also see kids that maybe have been exposed to an alleged perpetrator who another child has disclosed about. So whether that's siblings or cousins, sometimes we'll still see those kids and reassure them. You know, with a normal exam, which means there's no sign of injury or infection, a normal exam, we're not able to tell those families that nothing's happened to that child based on that, but we're able to reassure them that they're healthy. And then if there's concerns that maybe a child has only disclosed part of maybe what's happened to their bodies, there are times that we see kids a couple times in clinic because they disclose more in the future, that now there's different types of testing that we need to do based on that disclosure. So we'll see kids sometimes multiple times, or sometimes we'll, if the family wants to wait, we'll wait a period of time to see if the child does disclose anything additional. And before I move on to psychological or emotional abuse, we never do a genital exam on a child that doesn't want it, especially in an instance where sexual abuse or assault has occurred, because we're essentially doing exactly to them what has already been done if we move forward and they say no. When a child comes in, they have full say and control over their medical care. We want to empower them to make good medical decisions for themselves, and sometimes the best decision for them is to not have a genital exam, to not get their blood drawn, and to do that a different time when they're ready to do that. And we will always go with what the child says. Whether a parent wants an exam or an evidence kit done, whether law enforcement tells them you have to go get an evidence kit, if they say no, we do not do it. And we will advocate for that kid as much as we need to as to why we did not follow through with what law enforcement told the family to do. Because that can be a fear sometimes, is that the parents, like, they told us we had to come here and we have to do this. And there have been times I've had to call detectives or road officers and tell them, listen, we will not do this because of these reasons. The child has a say over their body and we are going to respect that. So we will only do it if they want that. It's hard to say because we wouldn't know what would happen even if they did. So, sorry, I'm not talking to the microphone. Even if that kiddo, so say it's a 16-year-old girl who said the assault happened that morning, she comes in and say she did get an exam and a sexual assault kit, the evidence kit. So say her exam is completely normal, which we would typically expect, unless she's complaining of pain or saying that there was bleeding. Her body at that point, she's gone through puberty, her body is made to do that. And so we wouldn't necessarily expect her to have an injury. 95% of kids, even after acute sexual assaults that have happened within that day or the past few days, have normal exams. 95% of those kids. That means only 5% have either an injury or an infection. So we don't know that if that kid had an exam, so say she had refused, we don't know that if she had had that exam, that would have made any difference for the case, because we don't know that she would have had an injury or infection. The percentage is just so much lower. Evidence kits, even when we do it within the time frame, does not always yield evidence. If the perpetrator was wearing a condom, if the perpetrator did not ejaculate in the child's body, we wouldn't have that evidence necessarily. And so that we wouldn't know if it killed the case unless we had known whether or not that evidence would have been there. Does that make sense? So it's hard to say. I have seen cases that have had evidence that a jury has not convicted. And there has been very clear DNA evidence that should not have been on that child's body, and the jury did not convict. And I have seen cases where there has been no evidence, and they've gotten 25 years. So it's really hard to say in those cases, and we really try not to use that as a reason to convince children. We don't want to coerce them into doing things. We make sure they understand what that means, especially the teenagers. When they say no to an evidence kit, we make sure that they understand what that means, that we can't come back and do this later. If we don't do it now, unless you come back in the next, in this time frame, that's kind of the last chance for it. And this is why we would collect it if you were okay with it. Once we've gone through all of that and they still say no, that's kind of where we leave it at that point. And yeah, we just don't know if it would have made a difference or not. But that's a really good question. Does anyone else have any others before we move on? Okay. I'm going to try and go a little faster for you. So psychological and emotional abuse, that is often very hard to spot, or maybe easy to spot, but it's hard to do much about, I guess is a better way to phrase that. Emotional abuse is one of the hardest things to prove and the hardest things to get children's services to open up. And that's because parents can yell at their kids. Parents can say mean and nasty things to their kids. And that does not mean that they are abusing their child. But when we're talking about constantly belittling, rejecting, isolating, terrorizing, even ignoring the child can be emotional abuse. But it can still be very hard for that to be investigated and something done about it. Some of the physical indicators that we see with kids that are experiencing emotional abuse, a lot of mental health, things like eating disorders, especially if they are being constantly belittled or made fun of for their bodies. We see eating disorders with that, sleep disorders, self-harming behavior, so something like cutting themselves, burning themselves, having suicidal ideations or attempts. Inappropriate bedwetting, so developmentally inappropriate, so a 16-year-old that's all of a sudden having bedwetting incidents or even at school having accidents. And then something we call failure to thrive. That can be something that's both a medical cause and it can be something that we see from neglect. So failure to thrive is most often seen in younger kids, but we have had teenagers that we would also classify as failure to thrive. But it's basically where they're not getting enough nutrition and their body is not growing appropriately. So oftentimes in infants, that's seen with babies that can't gain weight. Maybe they've been out of the hospital for 2 months and still haven't made it back to birth weight. Sometimes that's due to a mother's milk production. The baby's not, based on how they're sucking and swallowing when they're taking a bottle, they're not getting all the milk they need, and the parent doesn't recognize because the bottle's getting less and less, and it seems like the baby's drinking it all, but maybe a lot of it is coming out of the mouth, and they just don't recognize that. It can also be parents who don't want to get up at night, and so they don't feed their infants through the night, and unfortunately the baby's only getting fed maybe 2 or 3 times during the day, and then they're not gaining weight and thriving. So failure to thrive due to non-medical causes, so it's not a medical condition. There are medical conditions that cause kids to be unable to gain weight. One that specifically causes kids to throw up a lot, and so their bodies can't get that nutrition because they're not getting all the calories they need and taking all of that out of the formula because they're throwing it up so much. So we see that sometimes in older kids when there's psychological or emotional abuse occurring as well. So neglect, we talked before about there being the acts of omission or commission, which are, your physical and sexual abuse, and then you have your acts of omission. So that is a failure on behalf of the caregiver to provide for the child, whether that's a physical, emotional, we talked about education, so not signing up for school when they're supposed to and their grades behind. Medical, we see that a lot. Sometimes that is because they don't want to take their kids to appointments. That's less common than the family can't get there. They don't drive, they don't have a ride, they have used up all of their CareSource or Buckeye rides through insurance because they have 3 kids and this one child has had to go to 20 medical appointments in the last few months because of X, Y, and Z. You're only given 15 rides a year. So you've used up all those and you have no other way to get there and you don't have money to pay anyone to bring you. Because oftentimes the family or friends that are willing to bring, they want a gas card or something from that parent to do that. So we often see this medical neglect being something not purposeful, but something that unfortunately, due to lack of resources and support, the family just can't provide for them. Supervisional, that's, we talked about before, leaving your kids home alone who are not of appropriate age. To say that, Ohio does not have an age of where you can leave. It's another one of those weird laws we don't have. There's not a specific age that says you can leave your kid at home at this age and above. There's no age. So a parent could choose to leave their 10-year-old at home alone and say that kid has access to a phone. He knows how to call 911. He knows that if there is a fire, he's to run next door to the neighbor's house. And mom and dad have a specific time that they've said they're going to be home in, and the kid feels safe and comfortable being there alone. If you call the police on that, most likely they're going to leave and do nothing because the parents were being appropriate in the arrangements that they made. If you have a 5-year-old, that 5-year-old doesn't understand those situations, probably cannot react in the same way that 10-year-old could, and police would likely do a child endangerment charge and call children's services for that concern. So there's not a specific age, but you really have to use your common sense of, is it appropriate in this situation to do this? It may also not be appropriate for a 13-year-old to stay home for a week with an infant and a 3-year-old. So that situation may be a time that investigators need to be called. So that's a form of supervisional neglect. Another form is the parents there, and they just don't watch the kids. They let the kids run wild, and this kid has had 4 fractures, all accidental, but they keep getting fractures because mom's letting them climb on everything, and they keep falling off the entertainment center because she didn't follow the recommendations that we provided at the hospital. That's another form of supervisional neglect. We also know that neglect can lead to pretty serious harm and death at times. We have had children with pretty serious injuries that left them disabled for the rest of their life because of neglect situations. So it can be very serious and something that when we see the signs and we're concerned for it, that we try and intervene and do something about it. There are those physical signs of neglect. You see that maybe they're not growing the way that they should be. Oftentimes, the primary care physicians or hospitals, we keep growth charts. So we keep record of the kid's weight and height and everything. And we see that the first 5 years of the kid's life, they're following the right curve, they're doing everything, they're staying in the right kind of level they should be in, and then all of a sudden, the next time, they're way down here. That's a pretty drastic fall on the growth curve, and we would be concerned for what led to that. Was there an illness that caused that? There absolutely could have been. Or is it lack of access to food and water, that they just can't pay for food, so they're only eating 1 meal a day? So looking into those types of things. If they're wearing inappropriate clothing for the season, so it's winter and the kids only have t-shirts and shorts, that would be concerning for possible the family doesn't have access to proper clothing. Poor physical hygiene, constantly tired, that can also be a physical sign. But it can be hard to figure out what's the cause of these things. And oftentimes when we have families at the hospital where there's concerns for neglect, we do these things. So we're assessing for those possible barriers, things that make it difficult for the family to get access to the things that they need. We're considering what harm is this bringing the child. Has there already been harm, or is there a risk for serious harm to come by not doing something? Regardless of the motivation, if a child has been seriously harmed, or there's that potential, that needs to be immediate report to Children's Services. There are times that we want to give parents every opportunity. if they have had no access to a certain resource, our first thing is not to be like, we're calling children's services on you, you're a bad parent, because that's not true. That parent may be doing everything that they can and they still can't get that resource. So in those instances, we will utilize the resources in the community that we have partners with. And if they live in other communities, we will do the research to find where they can go to get this resource, or to make sure that they get to those appointments, or they get the formula that they need, before we instantly jump to children's services referral. Now, in instances where we talked about the failure to thrive, where a baby has come in, maybe it hasn't been something medical, and we figure out, okay, you haven't been feeding enough or you're making formula wrong, and we do the education, we give all the supportive resources, and they come back a month later and the baby has lost weight again. That would be a time that potentially we would make a referral at that point. But we want to give parents the chance to succeed. We don't want to just automatically be punitive that they haven't done something that maybe they couldn't have done on their own. So giving them that chance. But again, if there's been serious harm or risk of that, we would absolutely make a referral. So making reports. Sorry, I think the slide got mixed up. So this is kind of back to disclosures of abuse. So we'll talk about that first. So one of the things when we talked about disclosures, that's when someone tells another person something that's happened to them that shouldn't have happened. Most often we use disclosures as a term for sexual abuse, but they can disclose physical abuse and things as well. They're not going to disclose something when they're not ready to disclose it. You cannot force a child to disclose abuse to you by continuously asking them about it. At some point, they are just going to give you the answer that they think you want because they want you to stop asking them those questions. There are times that kids are coached to not tell, and whether that's by a parent, a family member, or friend of the family, that they're trying to protect whoever may have been a perpetrator to this child, so they've coached them to not say something. If that person has threatened that child, they may be fearful of telling, and so they won't tell until they are ready and that they feel that they will be safe, or the family member that that person has threatened would be safe if they told. Most often, kids don't disclose to adults, but they first disclose to peers. We kind of call that horizontal disclosures. Most of the time, those things don't get reported to investigators because peers don't know what to do with that. They don't know what to do when their friend tells them that their uncle sexually abused them because they're a kid too. So oftentimes those disclosures take longer to reach the appropriate people because it took longer than for that kid to be ready to tell an adult. Or maybe that friend finally was like, I gotta tell my parent, I don't know what to do, and they tell a parent too. Disclosures are a process, they're not a one-time thing. We often see kids disclose in a series of disclosures. The first time they disclose, they may only say a part of it, and then the next time they share more information, and by the time they make it to their forensic interview, maybe they've shared a lot more detail of that. It doesn't mean that they're changing their stories or they're being inconsistent. We hear that a lot. That term a lot used when kids are sharing just different details. And like we talked about before, trauma, the way it's stored in the brain, sometimes they don't remember it all at once. And they don't remember it in the way that you want them to tell them. They don't remember it in A, B, C, D way. They're remembering it C, Z, X, B. They're remembering it all in different orders. A lot of times, kids do report this feeling of relief after they do disclose. They've finally been able to tell someone the secret that has been eating them up. Or now they finally recognize that what's been happening to them for the last 5 years was wrong, and they finally were able to tell someone. So they often feel relief. When they disclose, what do you do? Because there is a high likelihood, when we're talking about 1 in 4 kids being abused, there is a high likelihood that at some point one of you has a kid disclose to you some form of abuse. So what do? The best thing, remain calm. Make sure you don't have, all these facial expressions and don't do things like, wow, oh my gosh, I can't believe that happened to you. But using comforting terms, saying, I'm so glad you told me this. I am here for you. You are safe, and you are so brave for having told me this. Being honest with them. is really big. Not telling them that you're not going to tell anyone because you are going to tell people because you need to keep them safe. So if I have a kid that is old enough for me to talk to, I'm going to explain in developmentally appropriate terms what I have to do with that information and why. If they are sharing all kinds of details, the biggest thing I can tell you to do is not tell them to stop. It can be excruciating to hear a child give you details of sexual abuse. Do not ask them to stop. Do not interrupt them. Whatever they share with you, do as soon as you can go back and write it down or put it somewhere that you can remember the details, do that, but don't try and stop them, because by you stopping them, they may take that as, no one wants to hear this, I'm gonna be in trouble, or this is too much, and then they don't wanna talk about it again. So that's one of the most damaging things that someone can do, is telling them to stop. We want them to be able to talk about it during a forensic interview, if they make it to that point. Hopefully they would. And then not questioning them further. There are times that you may have to ask a couple questions in order to report to the right people. And we'll talk about reporting, but we need to know kind of where things happen so that we can report to the appropriate people. So there may be times you have to ask a couple follow-up questions. Be as open-ended as possible. So closed-ended questions are, did dad touch you on the leg? That's a closed-ended question. An open-ended question, and I wouldn't necessarily use this as an example, but just an open-ended question would be, can you tell me more about that? That would be a good way to phrase that. If you need to know more about, maybe she's talking about where it happened, and see if she can share more without you specifically saying, was it dad's house? Was it uncle's house? All of that can lead the child, depending on their age, in a way that we don't want them led. Kids are very open to suggestion the younger that they are. So the way you ask a kid a question can absolutely change the way that they answer it, especially little ones. So we want to be really careful to not put words in their mouths. If they use different terms or foul language or whatnot, if you need to use that to ask a question to appropriately report it, use the same language that they've used. Don't use different language. Don't ask specifically about other body parts. We don't want to put words in their mouth that later could be seen as leading or coercing a child to disclose something. Just for the criminal process, that can be somewhat harmful. So the least amount you ask, the better. But if you have to ask a few things, if you feel like to report it appropriately, just try and be as open-ended as possible. So then, the Ohio Revised Code is what kind of dictates who is a mandated reporter and what that means. So all of you are mandated reporters by the very fact that you are volunteering with children. So a mandated reporter is a person in their official capacity, so on the time that you are volunteering, that you have reasonable suspicion. That word is key, suspicion. That does not mean I know for a fact that abuse has occurred. That means you're worried because you saw the kid with all of this ear bruising and he wouldn't tell you what happened, or maybe he's too little to tell you what happened, and you're now suspicious because you know ear bruising, that's an area of the body we don't usually see with accidents. And so you're suspicious. That means you have to report that. You are now mandated by law to do so. But if you're at home in your backyard having a cookout with your friends and you're not working in your volunteer capacity, you are not mandated to report that. As a good citizen, should you? I would. But you're not mandated by law. You can't be in trouble if you don't. That's often a concern with people about family members if there was ever a worry. You are technically not mandated to report against your family members when you're at home and see something. Should you? Yes, but you're not mandated by law. You can't be held accountable if you don't. And you should immediately report that. It's not something we advise you sit on for the next 2 days and think about it and question it. If you are questioning it at all, if you should report it, you should report it. So who's required to report? Like I said, volunteers, basically anyone that works with kids Healthcare professional is one of the top ones, but even people that work at daycare, people that work with developmentally disabled individuals, whether adult or child, they're mandated to report. You're also mandated to report elder abuse, so that you may see a lot less often. Maybe never with what you guys are doing, but it could be a possibility. So you would be mandated to report elder abuse as well. And then even if the child that you're reporting is 18, but they have significant developmental delays, you're still mandated even though they're 18 and they're technically not a minor. If they have significant delays, then Children's Services still becomes involved in those situations. So the people that you're reporting to are Children's Services and sometimes law enforcement. You are only mandated by law to report to one of them. So there are situations at our hospital that we always report to both because especially physical abuse, that's a criminal act, and both of those entities investigate. But there are times where a sexual assault, we only report to law enforcement and not Children's Services because she said it was a peer at school. Parent is completely appropriate. There's no concern for her safety at home. Parents are going to make sure that that person doesn't have access to her kid. Then law enforcement may be the only ones who would investigate that. But for your guys' purposes, I would always recommend Children's Services. And if you think law enforcement would be appropriate as well, do both. But I would always at least do Children's Services. The only problem with that at times is those sexual assaults where it is a peer. Children's Services, sometimes when they're older, when they're 16, 17, if it's a peer, they often screen those out, meaning they don't investigate. So if you only report to Children's Services, there could be the possibility, if the family doesn't call law enforcement, that then no one investigates that concern. But you're only mandated to report to one. A report made in good faith is confidential. So good faith means you had a reasonable suspicion that anyone else in your position would have had. You're not just doing this because you don't like that parent or you don't like what they wore that day and they seemed dirty, so now all of a sudden, you're worried for neglect. If you have reasonable suspicion of that, absolutely, you can report that, and that's considered good faith. You cannot, so it's confidential, so Children's Services, when they go out to the home, can't say that Betty over at this church made this report. They cannot release your name even in court or a civil action against you. And they can't, like a family can't sue you. We hear that all the time, that they're gonna sue the hospital, they're gonna sue us because we're calling Children's Services and calling them a bad parent. They can say that all they want. They can consult with an attorney. They cannot sue me for making a report. And we are very open and transparent. I tell every family, unless it will put the child at risk by telling them that we're calling Children's Services, I tell every single family why I'm doing it and who I'm calling. So we get that a lot, but they cannot sue you. So don't be worried about that. They also, you cannot get in trouble for making a report. So say you're like, I really don't know if abuse is occurring. I don't want to make a false report. A false report is something that you have knowingly done or caused someone else to knowingly do. So you knew in your head that you were lying when you made that report. That is the only time you can get in trouble for that. There are times that abuse is not found, but you had reasonable enough suspicion and an investigation was completed. You are not going to get in trouble for making that report. There are times, though, that if you make a knowingly false report, you can be charged with a misdemeanor, but I don't think any of you have to worry about that. So what to report? The most helpful information is as much information as possible, but you report what you have. Having the child's name and date of birth is key, knowing where they live, because that's going to tell you who to call. If they live in Dayton, you're going to call Montgomery County Children's Services. If they live in Xenia and they're coming with a family member to your guys' organization, you're going to call Greene County because that's where they live. Parent and caregivers' names are really important. If you have that, if you know how old they are, even if you don't know a date of birth, knowing a phone number. If there's other kids in the home, if you know that information or other adults that are in the home. and then obviously whoever the concern is with. So the alleged perpetrator is what they're called. So if that's mom, uncle, grandpa, whoever, if you know their name, or whatever nickname they called them. So if they call her Auntie Susu, then that's what you give if that's all you know. And it's their job to investigate who Auntie Susu is. And then location of where it occurred, if you know. If the kid said it happens at home or it happens at school or wherever, share that information. You want to give a summary of the information that you're concerned about. If the child has made a direct disclosure of abuse to you, so said directly, this person hurt me, use their words and tell them this is how the child told me this. And then any other concerns that you have with that. Trying to be as objective as possible. Again, we don't want to use subjective information like she looked at me wrong and I think she's a bad mom. That's not helpful information. If you have an objective reason for why you feel she's not a good mom, give that information. But that's that's an opinion that you have. So try and stay away from opinions and give objective information. So stuff that's real that you can see or witness. There are times that we get this a lot at the hospital where nurses will have concerns that a parent is high or under the influence. My first question is always, tell me why you think that. Is it, sometimes it's just, well, they're really acting off. Can you tell me what off means? Because that's not super helpful information, because there could be lots of reasons why someone seems off. They just may be an odd individual. We get that a lot. We see a lot of personalities. They may be very tired. We meet with families at 3 a.m. so often. They may be exhausted because their kid has been sick for a week before they ever made it to the hospital and haven't slept in 3 days. So we like to have really objective information. If a nurse can tell me her eyes are bloodshot, she is unable to follow a conversation, she is falling asleep while speaking, and she was stumbling while walking around. That is more objective information that tells me, okay, she may be under the influence of something. Sometimes it's prescribed medication that, again, on top of being sick and exhausted and stressed out, now all of that combined, mom just can't function appropriately. So we would go and assess those things. But again, if you see objective things like that you're worried that someone can't drive the kid home from your guys' place of, the Dream Center, thank you. I'm like, I just lost the name. Then that would be when you would want to call Children's Services and law enforcement because you don't feel like that kid's safe to drive in that vehicle with that person. So objective information is super important. And then if there's a concern for that immediate safety, so in that example, driving while under the influence could lead to an accident and that kid being harmed. That's immediate safety concern. If you know that that kid is going directly back to where that sexual abuse is occurring, that's an immediate safety concern. So making sure you let them know that from the beginning of the call, that you're worried that this kid is in immediate danger, because that will potentially change the way they gather information and get things a little quicker. They have a ton of questions they have to ask. It can take a while, and it can be exhausting. But if it's an immediate concern, they may ask a little differently, and they may call a supervisor much quicker to make sure they get a worker out immediately to you guys. They have an hour to respond in those instances. Otherwise, they have 24 hours to even determine if they will open a case and investigate, and another 24 hours to assign someone to go out to the home. Okay, so if it's an immediate concern, make sure they know that. If there's other kids in the home, make sure they know that as well, if you know. Oh, that's weird. They're all out of order. So things to remember, you're only mandated in your professional capacity. When you make a report in good faith, you can't be prosecuted. A report doesn't mean you're saying this absolutely happened. Again, it's just that suspicion. If you're concerned and you're questioning to report, just report it. It is better to report a concern and there be nothing going on than you not report it and that kid be experiencing some form of maltreatment that now no one knows about. So when in doubt, report. And then remembering your role. You're not an investigator. It's not your job to figure out what's true if the child's telling the truth. We talked earlier about how the majority of kids that disclose abuse are not lying. even the kids that tell lies all the time. That is the most common reason that parents tell me is why they don't believe their kid, is because Susie tells lies every single day. That doesn't mean she's lying about sexual abuse or physical abuse. Being supportive, involving the right people, and that every disclosure a kid makes should be taken seriously as if it's the truth, and moving forward that way. A couple things for prevention, and then we're done, I promise. So this is kind of important for you guys because you're one of our community resources, and we talked about earlier how important the community is in helping to prevent and identify abuse. So linking to other community resources, if a parent tells you that they don't have any food at home, if you can't help them with that in the moment, try to help figure out who can. Whether that's calling Dayton Children's and saying, hey, we have a family here who doesn't have food. What resources can you tell us about to tell them to go to get food? We have emergency food boxes for situations. There are certain hours during the day. Unfortunately, I don't think we can access them at night. But if it's during the day or whatnot and a family needs a food box, calling us, our social work department, our family resource connection, and we can make sure that there's a box ready for that family for them to come pick up that day. We have databases of resources in the community we can help link with. And hopefully you guys will be becoming familiar with Dayton's resources too, so that you guys can tell families about resources that are out there. Linking them to things like parenting classes. If the parent is talking about how they don't understand why their kids do these things and they just don't seem to understand child development, which is pretty common, seeing about linking them with an agency that offers free parenting classes. And those often involve talking about child development. We talked about how with infants, so much of that is reactionary. So understanding that a baby crying constantly is normal. That when the baby cries and you've checked their diaper, you fed them, they're not cold, they're not sick, and they're just crying, that babies do that at times. And what can you do to cope with that crying and still function, talking with families about postpartum depression, that is huge. Not only the mom, but the dad too, because the dad may be experiencing it, but the dad may also be the one that's now taking on the brunt of the responsibility because mom is so tired and she just can't do everything maybe like she was doing a few weeks ago because of the depression. Talking with them about talking to their OBGYN. Do they trust their doctors? Do they feel like they can open up to their doctor if they're telling you that they're experiencing postpartum depressive symptoms? And if they can't, helping them figure out who do you feel like you could talk to? And again, looking at community resources. Ensuring that they're receiving appropriate medical care. Again, if you have concerns that the kid is supposed to have an inhaler with them after school or whatnot, and they're never coming with their inhaler anymore, checking in with mom like, hey, I know they're usually getting this, but I haven't seen it in a while. Is there something going on that you guys need help with? And maybe it's they haven't gotten the ride to the pharmacy to pick it up and it's been there 2 weeks. And if that's something you guys help with, great. If not, helping figure out problem solving with the family. That's so much of what my job is problem solving. What can we do in this situation with what we have available? And helping walk them through that. Sometimes it's just having another person think through things with them that can click something into place and they're like, oh, I can do it this way. And then they can get access to that. And then educating on that child development. These are some really great resources online that I really encourage you guys to familiarize yourself with. The majority of these are related to sexual abuse, but there is physical abuse information as well. I utilize resources that are free from these websites almost every single day. The Mama Bear Effect is one of my favorites. It has coloring pages that are fantastic that talk about body safety, privacy, surprises, and not keeping secrets. That is a huge thing to remember. Teaching kids that we don't keep secrets, we only tell surprises or keep surprises, because we know that's something that is going to be told in the future. Oftentimes perpetrators tell kids that this is a secret, we're not going to tell anyone about these things, and if they don't know that secrets are bad, they don't think there's anything wrong with that. So the Mama Bear has great resources like that. Purple Crying is a resource. If you Google that, it's a resource that talks about crying in infants and helps educate parents with that. Stewards of Children is another resource actually that Care House does education with. Darkness to Light is the organization, but they do some training on that as well. It's all related to sexual abuse identification and prevention. So all of these are great resources. The majority of them have free stuff you can print out, give to families, read up on yourself. It's great stuff. So I encourage you to do that. And when you see something happening in front of you, when a parent comes and is yelling and screaming at their kid because they've had a really hard day, trying to intervene in the moment is probably the best thing in that moment. So validating how that parent feels, like, man, it sounds like you have had a really rough day. And then empathizing with them, like, is there something that we can do to help you? Like, this is just a hard thing you're going through. And then offering assistance of, can we maybe, keep the kid here for another 20 minutes while you go take a few moments in your car just to calm down, take a few moments to yourself and just kind of decompress. Whatever that is, but trying to validate, empathize, and then offering assistance in some kind of way, even if that assistance is just, we are here for you if you need to call us. We are here for you if you need to come and talk to us. And providing that kind of emotional support can be assistance. And maybe that's all that family needed to hear, and that parent can calm down. Trying to redirect to, sometimes it's redirecting the kid in the moment. If the kid's having a behavior outburst and the parent's getting really frustrated, sometimes just by redirecting that kid to, if you have a snack nearby, or talking about something on their shirt, that can completely change that kid's behavior instantly when you talk about the Paw Patrol dogs on their shirt, and now they're talking to you about all the different dogs on Paw Patrol. And that gives that parent then a moment to breathe and stop yelling, and then you can validate, empathize, and offer assistance. That was a really long time, guys. I talked at you a lot. I'm so sorry that took so long. What questions do you guys have, if any? Or anything more that you would like me to clarify more that didn't make sense or was confusing? Yeah. Oh.
Okay, in a case of a child being physically abused, I know there's parents that will abuse the child in areas to where they're not seen. Most times you'll see is their arms, their neck, and their head.
Absolutely.
But I know of a case, child being required to hold their hands over the other side of the chair so their arms wouldn't get whipped by the belt, and they were whipped from their back to their feet, but you wouldn't see that. Is there any other signs as far as child lashing out or child just shutting down that you would see besides the marks that they're being physically abused?
Yeah, so let me see if I can go back to it too. So we talked about with sexual abuse, some of those ways that kids will either act out or respond in a situation. So these can often be seen, I think I skipped it. These can often be seen with physical abuse too. So having anger outbursts, responding with violence. When kids learn their stress response, they're learning that from the people that are closest to them. So whoever their caregivers most often are. So if a parent's response is always to yell, scream, hit, oftentimes that's how that kid now reacts when they get stressed. So sometimes we see that with kids who are experiencing abuse. Violence is their response. So you may see that with kids that are hitting others and things like that. But there's no specific, like, you will see this, this, and this, and know for sure that there's abuse. There's just the signs of, the withdrawn, like you said, the anger. If they're in pain, and it's typically someone that, would go and play a game and now they're not and they're appearing in pain, that may be asking, hey, your back seems to hurt. Can you tell me why your back, or does your back hurt? Is there something wrong? Because you may not see it, and especially if this is an ongoing abuse and the parent or caregiver gets good at hiding those things and they know the spots that maybe others won't see. So that can absolutely be the case. And it's just trying to be that safe place, knowing that, letting kids know that you guys are safe, that if there's ever anything that they want to talk about with you, that nothing they ever say will get them in trouble, that you will always protect them, things like that. Reminding kids of those things, they're more likely to open up with people that they trust, and if they feel like they're in a safe place to do so.
How about a child that's being degraded on a regular basis, told, you're not going to amount to nothing, wish you wasn't born? Do they shut down? What signs would you look for that a kid's being emotionally and psychologically abused?
Yeah, so those can be similar behaviors, but there's also, and I'll go back to that one too, there are physical signs we sometimes see. So we talked about like self-harming behaviors, withdrawn, which I don't think is on here, but that kind of mental health things as well. So being withdrawn, isolating more. You'll often hear self-talk is often things that we've been told and heard ourselves. So the way we talk and speak about ourselves, when you have kids who are 4 years old saying, "I'm so stupid, I'm the stupidest person in the world," they probably didn't come up with that on their own. They probably heard that somewhere. Now, again, is that means everyone at home is telling them that versus they heard that on a show and another kid a sibling is telling them that? We don't know. But things like that. So self-talk can also be a way that you can recognize sometimes when there is that belittling aspect of emotional abuse. But the hardest thing for abuse, any form of abuse, when a child isn't disclosing, is identifying it just on behaviors alone, because those behaviors can be results of so many different things. So it can be so hard to spot abuse if the child isn't telling you about it or you don't see a physical sign of it on a body. Those are good questions.
So I always seem to have the most questions. So just information, at the Dream Center, we are going to be feeding people 3 times a week, and we have tons of donations, praise Jesus. And so we also want to be involved in like helping people in the community get food and stuff like that.
That's
We also
great.
have a clothing ministry, laundry facilities, showers, because we know that some people don't have access to those. And of course, the after-school program, parenting classes, marriage classes, anger management classes, those kind of things. So,
Yeah.
we want to help in the community as well. Do you guys use Care Portal? Have you heard of Care Portal?
So I think, is that like a database with resources?
Yeah, so apparently we've been looking into getting Care Portal for quite a while now. It just
Okay.
hasn't developed yet. But apparently churches get involved and they can give you their stuff to Care Portal.
Yes.
And then agencies can request stuff specifically for children, a lot involving foster care or trying to prevent kids from going into foster care. So I was just curious if you guys were using Care Portal's resources yet.
Yeah, so I don't think so. So our Family Resource Connection, we do donations through a lot of different ways, and they kind of, them and Child Life, Family Resource Connection and Child Life are the ones that kind of go and do all the donation kind of stuff like that. I don't think we use Care Portal. We use something called Aunt Bertha, which is a new thing, but that's slightly different than that. That's more of like a list of resources all throughout the different communities to link families with, but I don't believe we use Care Portal. I've heard of that with other churches. The more you explained it, I think my church does that, but we don't use that at the hospital that I'm aware of. Donations have to go through such a rigorous set of guidelines that I don't know that that's something that they would be able to do.
Okay. And then also, like, when we're like partnering, when referring kids to you guys, it sounds like if we question anything, it goes through Children's Services. And we know that Children's Services are completely inundated. It's just the reality. Everybody's aware. It's on the
Yep.
news, And so they're inundated. So at what point would we, I mean, of course, I would definitely call you if I was, needing a resource or something that maybe we didn't know about yet. But at what point would we call you guys in regards to children? Like, I know we would call if we know that somebody is being abused or suspect that they are, but at what point is a good thing for us to reach out to you guys?
Yeah, so we often get calls from other agencies, it's most often from like Children's Services or police when a kid is coming to us, and that's always so helpful to know ahead of time. So say there is a kid that gets identified of having injuries on different parts of their body, those kids need to be seen in the emergency department. Especially the littles who can't tell us if there are fractures or different things. You can have a baby that looks completely fine that has a fracture and you wouldn't know it. But even older kids who have lots of injuries, because one, we want to make sure there's not internal injuries. There's different lab tests that can help tell us that, imaging that we can see if they've got lots of bruising on their belly or their back. There's risk of spleen or liver lacerations, things like that. So if you guys know that, or I don't know your guys' policy on like if you would transport a kid, if you guys had a kid that you felt needed medical treatment, if you were bringing them to us, we would recommend you call us to give us a heads up so we can get details from you of what the concerns are and then find out what you've already done. If you've already called Children's Services and law enforcement and they're on their way, that's helpful for us to know so we can be on the lookout for them and get them to the right people and things right away. But yeah, really other times it's just whenever you have a question, if there's a situation you don't know what to do about, you guys can always call. If I'm not there and Kimber, my coworker's not there, we're the child abuse social workers, we have second shift, we have third shift, we have over 40 social workers in our medical social work department now that would be able to talk through what your concerns are, and if they don't know an answer, they will find the answer. We also have our child advocacy doctors, so we have 2 board-certified pediatricians, so they're board-certified in child abuse. They received tons of extra training and education on that. And then we have 2 nurse practitioners that also work with child abuse within our department, and there's always one of them on call 24/7. And so they, if you ever have a question and you're not sure what to do and there's not a social worker available to talk to you, you can ask the operator if there's someone available in child advocacy to talk to you. And if it's during the day, we'd be able to help link you guys with the right person. So those would kind of be the main times we would recommend that. I'm trying to think if there's any other time we'd have you call us, but I think that's really the most important things. If the kid's coming to us, and then if you just don't know what to do in a situation, we're happy to talk through it.
That's awesome.
What's the appropriate response when you're seeing something going on right there? Whether it's someone talking to their child, or in the grocery store, sometime when you see someone dragging Bobby down the aisle by his arm and that kind of thing. So there's 2 different ends of the spectrum. Some people just kind of turn and walk the other direction, or other people get right in the parent's face, which might make it worse and make everything escalate. What's the appropriate response?
Yeah, I think that's a great question, and that's often something I think a lot of people struggle with knowing what to do. We have a hospital full of people who are trained to work with families who the majority of them don't feel comfortable intervening when there's something like that they see. So we actually have a program at the hospital for our staff called Positive Parenting, where we've trained them in situations specifically like that of what to do. So the biggest thing we recommend is never being combative and never being aggressive in the way that you approach it. You want to be very open, very empathizing, compassionate. I would say the first thing I would usually do is, especially if it's a kid that's acting out, so the parent's now reacting to what they're doing, would be to try and redirect that kid. So we talked about before, talking about the shirt. I had a kid, one time I was walking through one of our waiting rooms, and he was having a meltdown, and he was diagnosed with autism, and he was probably about 4 years old, and he was just sensory overload. This was their last appointment out of 5 appointments, and parents had gone through all of the tricks. They have bags full of things for this kid to help distract and make him feel comfortable, and he was just done. And he was screaming his head off, so I walked by and I was able to start talking with him about his favorite character because he had him on his shoes. And I started talking with him about that, and he stopped screaming, and he instantly had attention and was then telling me about the stuffed animal he got. And that gave those parents who weren't responding in a bad way, but gave them that moment to calm down too and take a breath. And then I went and got him a snack, and he was able to sit there quietly until his appointment came. So in the grocery store, that's a little different. You can't just grab food off the shelves and give a kid some snacks or whatnot. But if you're able to kind of empathize with that parent and be like, you know, I remember when my kid was that age, it's so hard to take him to the grocery store sometimes. Can I do anything to help you? And just seeing their response. Some parents may be like, you know, brush you off and walk away and not talk to you. Some may be really open, and that gives them that moment of, yes, like someone understands me. Because you know probably when you had that moment that you were embarrassed, you felt like everyone is looking at me, everyone thinks I'm a bad parent. And that's probably exactly what's going through that mom's head at that moment. So just trying to empathize with them and validate those feelings of it is hard having a kid who is melting down in the grocery store, and then just seeing if you can help. That is much better than being like, I see the way you're yanking that kid's arm and you're going to hurt him and I'm going to call children's services on you. That is going to be a very, very bad response. Yeah, you will get a blow up explosion most likely from that parent. So it's always better to lead with love and kindness if you can, and just recognizing that anyone could be in that situation at that moment, and everyone responds in reactive ways, where the easiest thing at that moment is to yell at your kid and yank their arm to walk with you because they're laying on the ground in the grocery store and they won't get up. So that's most people's first instinct and reaction because they're frustrated. So just trying to kind of humanize that with them and recognize that and help walk, you know, if you can, help walk them to the door or whatever next area, you know, they have to go to, and see if that helps. Yeah.
What do you do in the case where, like, we had a lady that lived in our neighborhood, and she was physically and verbally abusive to her children, cussing, screaming out in the front yard. I talked to the police even about her. Nothing was ever done to them. What do you do when you have a case like that, or you see someone dragging their kid and slapping them, and you call the police and nothing's done? Or how do you even confront that in a proper way? Because I never confronted her.
Yeah.
I did speak with the police, but nothing was ever done. So I don't know.
Those can be really hard situations because you have to balance the concern of, one, this is happening and you're seeing it, and if you intervene, it could stop, but also it could get worse if now the parent's even more angry because her kid put on a scene in the yard which caused her to react to him and hit him, and now inside he's getting it worse because the neighbor came by and saw the commotion and she's more embarrassed and angry now. So in situations where there might be concern for further harm, I would recommend police. You did the right thing in that instance. I would recommend also calling children's services. You may not know their names, but you know what house they live at. You can give descriptions at least, and letting them know exactly what you've seen and heard. One of the hardest things, and we see this at the hospital, we see kids come back multiple times, and we have done all the right things by making all the right reports, and there are times that unfortunately the system fails and these kids keep getting hurt, and that is a really hard thing, and it doesn't sit well, you know, but you confronting in a situation may be beneficial and helpful, and you providing support and help of, you know, kind of like what we talked about before, but, you know, we've got some kids here. Is there ever a time that you want us to have our kids play out front, you know, and play together so you can have a little bit of a break? We'll sit out front and watch the kids while you know, take some rest inside. Even things like that, you know, that may not stop the abuse, but that stops it for a time at least. And you have some eyes on that kid, and maybe that gives you a chance to learn more about the family and see if there's other ways that could be, you know, help could be needed. But it's outside of children's services and law enforcement, there's not a lot that you can do. It's very unfortunate, and it's not great for our kids.
Any other questions? All right. Well, thank you so much for
Thank
coming.
you, guys.
Yes, we all need self-care. I need a bubble bath.
Yes,
now.
go do something nice for yourselves.
But we appreciate you. It was so wonderful, and we will be calling you. You know, we
Please
will be
do.
calling
That
you.
is what we are here for.
Yeah.
Thank you so much.